Thank you, everyone, for joining me. Today is a discussion about joints. As a longtime exerciser, joints are of great importance to me and have been kind of a bothersome thing, at least at different points in my life and currently. As I approach my 50s, I definitely feel the weight of joints, and I know that through a lifetime of exercise and has helped my joints, but has also been somewhat of a detriment too, as things wear down over time. And how we mitigate those things are really important. But any discussion about what we do for joints has to be buffered by talking about the structure and function of those things. So that's what we're going to talk about first here is joints and their classifications. So a joint essentially is an articulation. So it's any point where two bones meet. And so there's a variety of different type of joints that you experience that are in your body that we need to go over to make sure we have a good understanding of that. And the study of the science of joint structure and function is arthrology. And then to go along with that, the movement, kinesiology is the study of human movement. Now, joints and bones are really important because the big aspect is that is they serve as the lever system. That lever system is what muscles attach to cause movement. So any conversation about muscles has to also talk about bones, but particularly joints as well. So when we think about joints, we think about their structural classification and their functional classification. All right, what's the structure, the foundational context of this joint? Okay, and then we think about how movable is that joint. So we'll talk about that coming up, but something that's more diarthrotic is freely movable. And as we start moving down to amphiarthrotic and those things, you start getting less and less movement. What you're familiar with primarily with joints is mostly diarthrotic joints, the joints that you see and use on a regular basis for that. So we're going to start classifying things based off of structural and functional classification here. Both of those things very important to understand with doing that. So in classifying these, we look at a joint being bony, fibrous, cartilaginous, or synovial. Synovial, again, being the joints that you're more used to looking at. So your synovial joint, joints that you can see flexion extension, like flexion extension in my elbow, rotation, my shoulder, abduction, adduction, all these things. We're going to talk about those movements as well. So synovial is what you're generally used to seeing. So those are diarthrotic, meaning that they have the most movability. So they're highly movable. Cartilaginous joints are amphiarthrotic or amphiarthrosis, and these have limited movement. Fibrous joints have barely any movement, and then you have bony, which just have are no movement, or they are immovable. Okay, so structural classification, functional classification. Structural, the type of joint. Functional, how much movement it has or does not have for that. So bony joints, again, more immovable ones, those are joints that are formed when the gap between two bones ossify. Think about these bones are like fusing together, coming together. So examples of this be like left and right frontal and mandibular bones, especially what happens in infants, ischium, and the ilium down in the pelvis area, attachment to the first rib and sternum, and then parietal bones along the sagittal sutures that also occur as well. So think about this. The big thing I always think about bony joints is that they just don't move for that. Fibrous, you start to get some level of movement, but are almost immovable. So three types of fibrous joints we have are your sutures, gomphoses, and syndesmoses for that as well. These are bound by collagen fibers and emerge from one bone and penetrate into another. All right, so we have three different types of fibrous joints here, and I just talked about a little bit of that. And the sutures for these, again, the biggest one for this is up in the skull, up in your brain. Those sutures, which always look like to me, always like dividing lines, almost like state lines on a map a little bit here, but very wiggly here. Those sutures are actually forming as a child is growing, and then they become immovable with that as well. Gomphoses are attachment of a tooth to its socket, and these are held in place by periodontal ligaments. For that, the collagen fibers attach the tooth to the jawbone, and it allows the tooth to move a little bit under the stress of chewing. But can you imagine if there was even more movement, imagine chewing and your teeth just shifting all around. It's kind of a gross thing, actually. Let's not think about that. But that's what happens. So, all this working in purpose to allow you to be able to chew effectively and have that to solidify your chewing, but enough to be able to cause some movement, but not shaky jaking here. Okay. So, syndesmosis is a fibrous joint of which two bones are bound by long collagen fibers here. So this is almost like the picture you see where there's two joints and it looks like there's kind of a sheet in between it here. That's the syndesmosis too. So separation of the bones and length of the fibers makes this joint more mobile because of that kind of sheath in the middle there for that. So that's something to look at as well. Cartilaginous joints. These are two bones that are linked by cartilage. Get it? Cartilaginous joints. Okay. These are amphiarthrotic in nature, meaning that they are slightly movable, but certainly not diarthrotic, meaning that they're freely movable. So they have a limited mobility capacity here for that. So two types of synchondroses and symphyses for this. The synchondrosis are bones joined by hyaline cartilage. Now, hyaline cartilage is really important because the portion of that hyaline cartilage is definitely important in terms of helping to create smoothness of movement there, and we'll get into that a little bit more. Some examples would be like the epiphysis and diaphysis of a long bone in a child, which is formed by the epiphyseal plate cartilage, or the first rib attachment to the sternum. All right, so you think about that. When you think about the sternum here, okay, and you have the sternum, the body, right, the manubrium, and that first rib attachment there is part of that. The symphyses are two bones joined by fibrocartilage. So this is just like your pubic symphysis, which is down in the pelvis. So if you look at a picture of the pelvis, it kind of looks like two elephant ears coming down and then connecting, and kind of that fibrous area right down there with that connection point. That would be your pubic symphysis right there. So that's an example of that. So your synovial joints are now those joints that are diarthrotic and they are freely movable. Again, these are more what you would see as like, I guess you would say kind of the pop culture version of joints here. This, what you see is what you get. You're used to using it. It's a daily part of your life for most people, especially. So this is a joint in which two bones are separated by a joint cavity. Again, so these are the most familiar type of joint and structurally the most complex type of joint. And these joints are the one most likely to develop a painful dysfunction. So here's a good example to think about this. So think about shoulder joint, right? Your shoulder joint has all types of motion: flexion, extension, rotation, right? It has horizontal abduction, adduction, all these different movements here. And because there's so much mobility, there is a tremendous amount of laxity. So remember this term that in joints, especially like ball and socket joints that have a tremendous amount of movement, you're sacrificing stability for mobility. Because you're sacrificing that stability for mobility, the higher the incidence for dysfunction in that area. So what's something that's really common, which is a rotator cuff injury in that area, the sits muscle group, because there's so much movement in that area, and because the head of that area and the joint area there is fairly shallow, and that labrum area is very shallow, it's very easy for subluxation and dislocation to happen. A shallow joint with a lot of mobility equals lots of laxity, which basically equals not a lot of stability. But you want that stability to be able to move around. Same thing with your hip, ball and socket joint. Now, because it's much more fibrous down at the hip joint and the acetabulum over there, because it's a much deeper groove there, it's less likely to have subluxation or complete dislocation of the hip joint. I've actually seen dislocation of the hip joint. It's pretty gruesome, but extremely rare because of the acetabulum being so deep and the number of fibers connecting that area is so strong. It's very difficult. A hugely traumatic event has to occur for it to be a dislocation of your femur, basically from the acetabulum. I mean, it sounds really gross because it is. It's much easier for that to happen up in the shoulder joint, again, because the amount of movement, but also the very shallow labrum there and fossa in that area that allows for that movement. So it's actually really important for you to strengthen your hips and shoulders quite a bit. In my training practice, it's something that we do constantly. I'm always working with hip movement, shoulder movement, and trying to create stability and mobility in that joint with either body weight or external resistance, because these are the areas where people have the most dysfunction and a lot of pain. I'm sure you've known tons of people in your life who've had shoulder pain, hip pain, also, and then redirecting that to lower back pain, all those different things there. So, because of the movability of that joint, you're sacrificing a lot of stability. So, remember, lesson on this, especially synovial joints, especially ball and socket joints, is you're sacrificing stability for mobility in that area. So, again, these are pretty important joints for people or any profession, healthcare profession, nurses, fitness trainers like myself, athletic coaches, therapists. That mobility in that area is critically important for quality of life. So you've seen what happens, right? When someone loses their ability to have mobility, it drastically decreases their functionality in life. And what happens with our joints when people have a lot of joint issues and especially start losing mobility? People start to shrink their lives to fit their lack of mobility and their joint capacity. So, how does this occur, right? So, maybe in the past, you took the stairs a lot because your knees never hurt or never had issues there. And then all of a sudden, you start taking the escalator or elevator quite a bit, right? Or you no longer, because you have problems with your ankle and your knees, your shoulders, instead of wearing shoes where you tie them, you start wearing Velcro or slip on shoes, right? You shrink your life based off of your mobility. The more mobility you have in a joint, the more likely you are to be more adventurous and do more activities of daily living that make you more active. The more dysfunction you have in the area, the more you're going to shrink your life. And often what this does is just creates more impairment because you're not actually doing anything anymore. There's tremendous atrophy, less movement, and essentially the joint is no longer being oiled anymore. And then you get a huge amount of stiffness and dysfunction in that area as well. So I always look at synovial joints are the joints of life quality. And when these aren't optimized on a regular basis through exercise and external resistance, we're actually just atrophying that area quite a bit. So again, just a lesson to think about there. In the structure of synovial joints, we have articular cartilage, which is a layer of hyaline cartilage covering the surface of the two bones, okay? And so then we have that separated by the joint cavity and then synovial fluid. The synovial fluid is the lubricant in the joint cavity. So this nourishes articular cartilage. This allows the cartilage, this actually allows the joint to have smoothness of movement, so you don't want to have the friction. And in basic physics, right, and friction and more coarseness creates more resistance. We need less resistance, so we need less friction. How do we create that? Hyaline cartilage, the production of synovial fluid, allows for smooth movement in the joint cavity. Okay, over the course of time, if you're a regular exerciser like I have been my whole life, while exercise helps to fuel the nourishment of these joints, it also does another thing that over time you get wear and tear. Think about the brakes in your car, right? Over time, you have to replace the brakes or have. Now, this is a car. You don't often have to do this all the time with humans, but when you have a machine, the parts wear down over time. And you are constructed very much like a machine, or we could say that we construct machines very much like the human body. Those things start to wear down over time through usage. Just happens. The human body in itself is essentially a ticking time clock. And our goal with having modifiable lifestyle factors is to mitigate that, to slow that down so that basically the disintegration of the joints isn't happening as quickly there. So movement helps to nourish those joints and the synovial fluid, but over time they can break down over time due to just regular participation and being active. All right, so when we look at the capsule of the joint, this is the connective tissue that encloses the capsule and retains the fluid in that area there. So the outer fibrous capsule is continuous with the periosteum, joining of the bones. The inner synovial membrane is composed mainly of like blast-like cells that secrete that synovial fluid within that there. Okay, so again, what's so elegant about the joint system is that there's all these design factors in place that help for smoothness of movement So instead of there being crunching, cracking, breaking sounds, it's generally just quiet. Now, I know that some of you are like, man, my knees sound like an explosion all the time. What's going on? Well, there's a lot going on with that, but certainly that the construction of something like the knee, where there's a lots of padding and synovial fluid, are helping because this is our flexion and extension movement and our walking on a regular basis here. So we have usually some version of articular disc or a pad that goes across the joint capsule. Think about it kind of in a way of like if you were sleeping on a bed, and a bed that had no, it just basically was just like a hard bottom of your bed. So, like in your bed, you have like the spring mattress, right? Imagine if you were just laying on the spring mattress, and imagine if there was no cushion above that and then no bed. That's essentially what would happen if you didn't have your meniscus, you didn't have the synovial joints. It would be uncomfortable for you. So, what do? We buffer those things, especially with our beds, by making it more comfortable with that, adding more padding. And your joints generally have this built in system with things such as a meniscus, which is like a crescent shaped moon pad that does not cross entirely the joint, but again helps with padding, especially in the knee for that, and the shock absorption and pressure also stabilize the bones. One thing to think about here is the type of shoes you're wearing is really important. So, shoes, but even further than the shoes is the insoles. Do you know that most shoes actually fail after 100 miles? Pretty crazy, right? And the insoles are the cheapest part of the shoe, costing on upwards of around 20 to 40 cents in production, and are the cheapest version, but is the biggest part of the shoe that helps you with shock absorption. Kind of crazy, right? What happens is we get so enamored with the style of the shoe and how it looks, the aesthetics, but we don't see what's going on underneath the hood, which is that the insole is actually very poorly constructed and doesn't actually do a good job of shock absorption. So think about in your shoes, the insole is the meniscus. It is part of the synovial fluid. It is the padding. So what if that's done poorly? More shock, less shock absorption, more injury happening for that together. So something to think about with that. Some accessory structures associated with the synovial joint would be tendons, which are strips of collagenous tissue attaching muscle to bone, ligaments, which are attaching one bone to another, and bursa sacs, which are fluid-filled sacs with synovial fluid located between muscles where tendons pass over bones or between bone and skin for that. Then there's also tendon sheaths, which are elongated like cylindrical bursa wrapped around a tendon. And these are abundant in like your hand and your feet area for that. All right. So more information. This is one of my favorite about exercise and articular cartilage. So one interesting thing with exercise is exercise actually warms the articular cartilage. So it makes it less viscous, so more easily absorbed by cartilage. So because cartilage swells and then provides a more effective cushion for that. So a warm-up period before vigorous exercise helps to protect cartilage from undue wear and tear. So warm-up is really important. Now, increasing body temperature is important, and we think about this not necessarily in terms of our articular cartilage. We always think about it primarily in just increasing body temperature and getting ready for what we're going to do. But it also is such a big deal for articular cartilage as well. So repetitive compression on non-vascular cartilage during exercise squeezes the fluid in and the metabolic waste out of the cartilage. Think of it as kind of like a pumping system, a squeezing system. So each time the weight is removed, cartilage absorbs this synovial fluid, kind of like a sponge, right? Think about that's coming in and its sponge is taking it out and taking that oxygen and the nutrients to different areas, the chondrocytes in the body. So without exercise, cartilage deteriorates more rapidly from inadequate bone nutrition and joint nutrition and waste removal because of what we're doing with our bodies, we're building up a lot of waste. I mean, think of the process of we're taking in nutrients, we're always doing different activities, and the byproduct of a lot of our activities and our intake of digestion is waste and buildup of heat and water and all these different things here. So without exercise, actually, it decreases our cartilaginous health there. So exercise causes that squeezing fluid action there that helps to nourish the cartilage and the joints. So another kind of whack against being sedentary, right? And you notice this when a person is not active regularly, something is always going on with their joints. They don't feel good. They're stiff on a regular basis, right? So being sedentary is essentially like having lubrication, not having lubrication for the different joints for that. But again, think about this too, is that even when you're exercising regularly and nourishing the joints, that still doesn't mean that the joint doesn't wear down over time, just due to the accumulation of exercising regularly. And all those aches and pains and things you feel as you get older, these are not uncommon, especially if you spend a lifetime working out regularly and putting resistance against your body. You're going to feel some of the effects of a lifetime of wearing down those joints there. So let's talk about range of motion. All right. So range of motion is the degree through which a joint can move. Now, we know that having limited range of motion drastically affects quality of life. Right. So we talked a little bit before about the importance of synovial joints and moving those synovial joints regularly, nourishing the joint, actually the joint itself. And range of motion is no difference. And this is really, range of motion is determined by the structure of articular surfaces, by the strength and tautness of ligaments and joint capsules, and the actions of muscles and tissues. All these are factors in your range of motion for that. All right. So we have 6 types of synovial joints. Again, we focus on the synovial joints because these are the most important joints, because these are the forward-facing joints. These are the ones you are using on a regular basis. As I'm extending, flexing my elbow here, synovial joint, hinge joint here, flexion, extension at the elbow. Let's talk about those different things here. So 6 types of joints that are found in the upper limb. In order, we're going to do this in order of descending mobility. Okay, so multi-axial joints, or also called ball and socket joints, are again what I talked about with the shoulder joint, hip joint, where you have a tremendous amount of laxity or mobility, but you lose a lot of stability in that area. Biaxial joints, which be like your saddle or plane joints, and monoaxial, which would be like pivot and hinge joints. So you see, you go from a lot of movement, a lot of diarthrotic movement, and it decreasing that mobility as we go down there, where like basically a hinge joint does one action, flexion, extension here. All right. So let's talk a little bit deeper about this. So ball and sockets, these are more of your smooth hemispherical heads fitting into like a cup. So think about, you have kind of like this instrument. So you have the ball, the head that fits into a cup here, okay? And then creates a lot of movement here. So these are the only multi-axial joints in the body. So essentially like the shoulder joint or the glenohumeral joint, the shoulder and the hip joint. These are your 2 ball and socket joints. Again, they're much easier to injure, primarily because they have not a lot of stability. Now, we'll say again, as we review the hip joint has way more stability than its ball and socket cousin, the hip joint or glenohumeral joint, primarily because it's a much deeper joint system there and much more fibrous in that area versus in the glenohumeral joint there. Your condylar joints or ellipsoid joints are oval convex surface of one bone fitting into a complementary shaped depression on the other, and just have movement in 2 planes. So think of your radiocarpal joint, metacarpal phalangeal joints at the wrist and at the hand, okay? Then you have your saddle joints, okay? So example of these would be like your sternoclavicular joint, the sternum clavicle meeting here, your opposable thumb. These are bones that have an articular surface that's shaped like a saddle. One is concave, the other is convex. For that, we have our gliding joints or plane joints. These are flat articular surfaces, bones sliding over top of each other. Plane joints, bones sliding over top of each other. These are usually biaxial joints. So think about the bones between the carpal bones of the wrist, the tarsal bones and your ankle, and the articular processes of the vertebrae as well. Then you have our hinge joint, which I talked about. Your knee joint is very much a hinge joint. Elbow joint, where you have flexion, extension. Flexion, extension. So that's freely movable in one particular plane. This we also call a sagittal plane of movement. We have flexion, extension happening in this plane for that. And then pivot joints is a bone spins on its longitudinal axis. These are monoaxial, mono being one. This will be your atlas and your axis joint for like C1 and C2. Okay. So again, spinning on the longitudinal axis. When you do cervical rotation, so if I look left, I look right. This is happening at my C1, C2 atlas and axis there. Okay. The bone is spinning on a longitudinal axis. So when I say no, no, I'm pivoting to say no on my longitudinal axis. So cervical flexion equals no for that. All right, so let's look at some movements of synovial joints, okay? So we're going to look at this in terms of referring to a person standing in anatomical position, which is standing straight up here with our arms out, palms facing forward here. Each joint is in zero position, okay? So joint movements describes as deviating from zero position or returning from that zero position. So we talked about flexion and extension. Easy one to remember is biceps, right? If we're doing a bicep curl, we start out in extension and then flexion. Back to extension, flexion. Same thing with my knee. You can't see it on the table, but if I extend my knee, then flex my knee for that. One of the things I think is really important is to actually call movements by their movement instead of making up gimmicky things. In fitness, we do this all the time. We make up really gimmicky activities and exercises, but I prefer to call them by their technical names. One, it helps me to remember when I do that. For example, if I'm doing a hip-based exercise, I say, oh, we're going to be moving laterally, doing hip rotation, or we're going to do our lunge where we're going to flexion at the knee, extension at the hip for that. One, it helps to build in remembering the movements. Two, you're actually teaching people that you're working with what these movements actually are. So in flexion, we're actually decreasing the angle, or the joint angle here. In extension, we come back to zero position, okay? So those are your most common. Sometimes there's hyperextension, but that's often pretty rare. That's almost too movable, too diarthrotic there. And you can also see extension in shoulder. So shoulder flexion, extension. There's some hyperextension as well. Flexion and extension happen at the hip. So when you flex your knee and you flex your hip at 90 degrees, you have hip flexion, bringing back down to the ground, hip extension, or swinging your hip back, hip extension as well. I use a lot of these because, again, I believe it's incredibly important to strengthen the most lax joints because these are the ones that give people the most problems. Then we have abduction and adduction. So think about these terms. When I abduct, I take away. When I adduct, I come back towards the midline. So abduct, away from the body, away from the midline, moving laterally. Adduction, adding it back to the body towards the midline here, okay? This is often done, this is done in the frontal plane of motion. So any movement that is abduction, adduction, a pretty simple one is a jumping jack, which is done in abduction and adduction. We have elevation and depression. So elevation raises a part of the body vertically. I always call this the question, like, I don't know. Elevation, coming back to zero, is depression for that. So elevation, movement that raises the part of the body vertically. Depression, a movement that lowers the body back in the same plane, back to zero position there. Protraction and retraction, I like to call this the push-pull movement here. So protraction, all right, is when the anterior movement of a body is in the transverse plane. So we're pushing out. So what happens when I protract my scapula, okay? Protract, so pro versus retract. I retract that statement, bring it back, okay? So think about when you're doing a seated row, right? When I pull the row back, I'm retracting my scapula, okay? The scapula is coming together and retracting. When I protract it, the scapula comes away from each other, okay? So the protraction is anterior to the front. Retraction is posterior to the back. Anterior, posterior for that. Circumduction, okay, is when one end of appendage remains stationary while the other makes a circular motion. So think about circumducting the upper part of the limb. Think about someone, let's say if one part of your limb is like this, right? And then you just move the other part here, circumduction. Also with your thumb, circumduction happens here as well. Then we have rotation, which happens in the transverse plane. A lot of rotation movement is which a bone spins on its longitudinal axis. Okay. When I do rotation, I can do, for instance, I could do internal rotation at the elbow. So internal rotation, turning the board inward, and then I do external rotation. So internal, which is like medial rotation, external, lateral rotation. So we're turning the bone inward towards the midline, or we're going to do lateral rotation outward away from the midline here. Okay, rotation. Also do rotation at the spine, right at the lumbar spine. I can rotate, turn on the axis one way, rotate, then do into the other way here. Next one, we have supination and pronation. Okay, so supination primarily occurs in the forearm. So supination is a forearm that turns the palm to the face anteriorly or upward here. Okay, so I think supination, palm facing upward. Pronation, palm facing downward. Okay, pronation, palm facing downward or posteriorly. So supinate, pronate. Or think about also if you're in a plank position, all right? Or in a prone plank position, when you turn over to the other side and lay down, you're in a supine laying position, faces up, palms out for that. That may be another way to look at that too. All right. Some other movements of the head and trunk. So you could think also that at your trunk or at the spine, at your lumbar spine, you could also flex and you can extend. So extension comes back to zero, flexion down at your spine. So flexion, extension, you can do. You could also do lateral flexion as well. So think if I'm doing like a side bend, old school term here, but lateral flexion to each side as well. You could do hyperextension at the spine as well, which is like bending over backwards would be an example of that. So just some other terms, other movements here. Is again rotation at the cervical spine. Again, C1, C2 is an example of that as well. You have other special movements that also happen, like your mandible at the jaw, and then also you have your hands as well. So you have like ulnar flexion and radial flexion, so called like the waving movement, right? Ulnar flexion, radial flexion here. And then you also have other special movements that happen with your fingers, the toes. For example, when I point my toes up towards my shin, I have dorsiflexion. And when I point my toe back down, kind of the dancer's toe, I have plantar flexion for that. So again, just some special movements to be thinking about that happen only in certain parts of the body. Okay, so it also, like at the foot, you have things like inversion, eversion. Think about evert my foot out. So if this is my foot, right? So if I evert, eversion, inversion inside, I can move my foot inside or outside. I could dorsiflex or plantiflex as well there, right? All right. Whew. A lot of stuff for the joints and movements that occur at these different things. These are the main ones that you see here. But I hope this was very helpful for you when looking at joints. I always like to look at the joints in terms of the structure and function of the joint, the capsule, the synovial fluid, and then really focus in on the movement of it. And then look at the type of joints and what happens at these different things. I always looked at it too, is that when I'm trying to remember the movements of different joints, also recognize that certain joints have movements that are only for them. Like I just talked about dorsiflexion, plantar flexion, which happen at the foot, the ankle there. Those are synonymous with that. Primary supination, pronation, very much with the wrist joint, experiencing that. Cervical rotation at the C1, C2. Remember those. Flexion and extension occurs at a lot of joints and things of that nature there. So just try to remember that sometimes movements at joints are very specific for that place only, such as like protraction, retraction as well. All right, that's it for now. I really appreciate you guys giving me all of your time. I hope you enjoy these videos, and I will talk to you next time.